College Hospital. So I'm going to present two journals today, and before that, I would like to thank all the scholars from all corners of the world to allow us to meet you, and we Ethiopian Journal Club group are really honored, and would like to thank you with great pleasure. So before, am I audible? So before proceeding to my presentation, I would like to say something about Ethiopia. And Ethiopia is one of the most populated country in the Horn of Africa, with land area of more than 1,100,000 square kilometers, and its capital city is Addis Ababa, and this green shaded map is the map of Ethiopia, and the flag of Ethiopia looks like this. And Ethiopia is one of land of origin for human being, evidenced by archaeologists as the origin of archaeological fossil of Lucy, if you remember from history. So it is land of origin for all of us, human being in the world, evidenced by the well-known international archaeologists. And also it is an origin of river, Blue Nile River, which is the biggest river in Africa. And Ethiopia also is populated with more than 86 nations and nationalities, and Ethiopia's population and people are welcoming to everybody, for tourists coming from different corners of the world. And also Ethiopia is well known by its hospitality. So it's bordered by 6 countries in east of Africa. So we are welcoming for everybody coming from a different world, parts of the world, and we have different beautiful tourist centers. So having said this about Ethiopia, I will invite Dr. Antena to say some brief about history of plastic surgery in Ethiopia. Thank you. Dr. Antena, please. Dr. Antena.
Hello.
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 Can you hear me?
Yes, yes.
I can say a few words if Dr. Antena is not able to connect.
Thank you, Dr. Makonnen.
You know, my name is Makonnen. I'm a consultant plastic surgeon at Addis Ababa University. We are doing training. The history of plastic surgery is just very recent. We usually divide it before 2020 and after 2020. Before 2020, there was 2 plastic surgeons for the whole country. One was a Korean plastic surgeon who practiced at Addis Ababa University for more than 26 years. And the other was an Ethiopian who was trained in England. So in 2020, training was started sandwich type with the support of the Norwegian government. And also 2 units established. And doctors were enrolled for training. The first were mainly general surgeons. I was one of them, and actually I was a third part from that group. And now I think currently we have more than 40 plus surgeons practicing at different parts of the country, and there are, I think, around 30 trainees at different stage of their training. Even though it is recent, but it is progressing well. I think we'll be catching up. That's it. Thank you very much. Thank you also for the opportunity to participate, and I'm really happy that I was invited to participate in this important event.
Thank you, Professor Mikael. Is the presence of the Ethiopian Plastic Society?
Yeah.
Thank you, Dr. Mokonnen, our most honored teacher. I is currently president of Ethiopian Society of Plastic Surgeons, and is also consultant for East African Smile Train, and also he's a member of Smile Train Research, and he's also head of Unethical Committee of Ethiopian Research Ethics. And thank you very much, Dr. Mokonnen, to join us.
Thank you.
Let me proceed to my presentation. So the first presentation will be on descriptive epidemiology of orofacial clefts in Ethiopia. So this journal was published in the Journal of Craniofacial Surgery in 2017 and volume 18. So the authors are different scholars. The main principal investigator being Dr. Mokonnen Shete, who participated in every aspect of the research, and the others from different institutions and from other countries other than Ethiopia participated in the journal. So when you see the introduction, orofacial clefts are the most common craniofacial birth defects, and the worldwide birth prevalence is estimated to be 1 in 700, and it varies from 1 in 2,500 to 1 in 500 births, depending on the geographic origin, on racial and ethnic backgrounds, and socioeconomic status. So according to the research done by Des et al., Asians have the highest risk, being 14 in 10,000 births, followed by whites 10 in 10,000 births, and usually in African Americans and in black it is low, and 4 in 10,000 births. There has been varying reports and rates from Africa, and Khan reported birth prevalence of 1.65 per 1,000 births in Kenya, and Odimbo et al. Reported the prevalence of 1.5 in 1,000 births, and Suleiman reported prevalence of 0.9 in 1,000 live births in Khartoum, Sudan, and Sadan et al. Reported prevalence of 0.7 in 1,000 live births in Uganda, and the report the reported rate of orofacial clefts in Nigeria are low. As two researchers showed 0.3 in 1,000 in eastern part of Nigeria, and the country-wide prevalence of was estimated to be 0.5 in 1,000. So the incidence and prevalence of these anomalies in Ethiopia are not known. It was not known, and also country-wide prevalence is still not known. The reason being because of no community-based study done yet, and no established birth defect registry system in the country yet. And currently, there are published reports about these anomalies in Ethiopia, but all are hospital-based, not community-based nationally. So a study among surgical patients in those less than 14 years of age admitted to Ethio-Swedish Children's Hospital in Addis Ababa was done more than 20 years back, from 1984 to 1988 Gregorian calendar, and the total prevalence was the 8% cleft case were admitted. And study conducted at Addis Ababa Health Institution reported an incidence of 1.49 per 1,000 live births. And orofacial clefts represent significant public health problems because of their treatment requires comprehensive surgical, orthodontic, speech, and psychological team approach and team management. And in Ethiopia, there is only one center that provides this multidisciplinary cleft care in the entire country. The objective of this study is to investigate the prevalence and incidence of orofacial clefts in Ethiopia. And the method, this was a retrospective hospital-based descriptive study done in more than 31 public and private hospitals who are distributed throughout the country. And the ethical clearance was retrieved from College of Health Science at Addis Ababa University. And data sharing agreement was signed between Smeltrain and the investigators, and data of operated patients from 2007 to 2013 were collected from those more than 31 hospitals which are distributed throughout the country, as I said, private and public hospitals too. And the total number of live births during the study period was obtained from the Federal Ministry of Health database, and the frequency table and binomial tests were done. Inclusion criteria were data of all cleft patients who received single surgical treatment at 31 hospitals with support of Smeltrain, which was found to be complete. And exclusion criteria, all individuals with undiagnosed or unoperated clefts were excluded. The result of the research, the article was 18,000 participants were found with cleft lip and palate who were operated. Of this, more than 8,000 were under 7. Live births during this period of study, within this 7 years period of study, were 811,316, and this gives an incidence of 0.44 per 1,000 live births. The prevalence found in this study was 0.2 per 1,000 live births. It was estimated using the total number of clefts, which was 18,000, and the total population in 2013 was 88,703,914, and the syndromic and atypical clefts were not included in this study. Most of the individuals operated had unilateral cleft lip only, and cleft palate only was the least finding in this study. So the laterality distribution of the cleft type by gender showed bilateral, the unilateral cleft lip was more prevalent, and cleft lip palate was least one. The difference in proportion were tested and showed that the proportion of bilateral cleft lip palate was smaller than the proportion of unilateral, and right and left lip and palate. All p-values were less than 0.001. The prevalence of left cleft lip palate is smaller than the proportion of right cleft lip palate, and the p-value was also less than 0.0036. The proportion of left cleft lip only was bigger than the proportion of right cleft lip only, with p-value less than 0.0001. So this is a test for difference in proportion. So the discussion part of this study, in this study, isolated cleft lip only was the commonest cleft type, and isolated cleft palate was the lowest, estimated to be 3%. And this is similar to other African studies, and the reason might be lack of proper examination of the newborns. The incidence and prevalence rate reported in this study was less than what has been reported in previous studies in Ethiopia and other African countries. And all cleft types were common in males. And this might be because of the priority being given for male for the treatment to be sick by parents. When you see the recommendation, now this article due to lack of information on incidence was due to non-existence of established birth defect register system as the nation. So the researchers highly recommended establishing a system of birth defect registry to know the burden of the birth defect, including cleft lip and palate as a country, and creating awareness to the community and health professionals about the cleft condition may improve the visit of the cleft palate and lip and palate patients, including females, and conducting further community-based study. So this study was hospital-based and web-based, only done on those patients who visited the small trained surgical program. So those who didn't get the surgical treatment and who remain in the home due to different reasons were not included. So this research based only on the hospital-based and particularly those who visited surgical treatment. So this is the limitation. And the strength is the study was done despite all the challenges in conditions, including lack of registry system in the country, and the baseline, it will serve as a baseline study for the future researchers, and the source of data was reliable, being documented by SMILE trained database, and different scholars from different setups were involved with their different expertise in the article. So I'd like to pass my great thank to organizers of for this opportunity to show the prevalence and incidence of cleft lip palate to all of you who are participating in this meeting. And I will also like to thank my teachers from both Cleft, from both plastic surgery centers, from Yekatit 12 Hospital and Alert Hospital. So we have two main plastic surgery training centers. Let me introduce by this opportunity. One is Alert and the other is Yekatit, the two largest, two most well-known plastic surgery training centers. So thank you.
Thank you.
Thank you, Dr. Adam. We can proceed for the next article, then we'll do discussion for both articles together.
Okay, thank you. So my second article is on repair of complete bilateral cleft lip with severely protruding premaxilla, performing a premaxillary setback and vomerine ostectomy in one-stage surgery. So this article was published in the Journal of Med-Oral Patholoral Cerebral in 2015, and it was published in Spain. So the authors were Nabil Fakhi-Gomez et al. At the Department of Maxillofacial Surgery in the Virgin del Rico University Hospital in Spain. So the authors in this research have presented a technique of premaxillary setback for selected cases of complete bilateral cleft lip repair. And protruding premaxilla is the characteristics of children with complete bilateral cleft lip, and bilateral cleft lip repair with severely protruding premaxilla remain one of the most challenging problems for surgeons, essentially due to difficult muscular apposition. So premaxillary setback was done by reductive ostectomy on vomero premaxillary suture, and it has been done in patients who didn't get access to pre-operative orthodontic treatment. So the patients and methodology in this article was number of patients were 4, 2 females and 2 males. Age group was ranging from 7 months old to 4 years and 5 months old, mean age being 19 months. And study period was from December 2011 to April 2013. Type of study was single institution based case series, and the inclusion criteria was patients with cleft, complete bilateral cleft lip and severely protruding prominent premaxilla, and who didn't have pre-operative orthodontic appliance. So the surgical technique under general anesthesia, the procedure began with vomerine ostectomy, and bone was removed anterior to the vomero premaxillary suture, and simultaneous gingival periostoplasty was done, followed by suturing orbicularis oris muscle, and they were using Miller technique for repair, and alar cartilage were readjusted through re-incision, but primary nose correction was not done. And from 4 cases, the first case, the palate cleft palate with vomerine ostectomy was done initially, followed by new lip repair 4 months after vomerine ostectomy, because of other lip surgeries were done in other hospitals before referral without treating the protruding premaxilla. And the other 3 cases all underwent surgical technique described in the previous slide. So the extent of premaxillary setback varied from 9 mm to 16 mm. And this was the first case, and older in age, with 4 years and 5 months old. And if you can see, this was a pre-operative image before the intervention was done, and this is post-operative image. So this is the second case image, preoperative and post-operative image subsequently, the third case, and the fourth case image. The results were they achieved good lip repair in all cases with adequate muscular repair and an excellent symmetry of lip, prolivum, and cupid's bow, and as well as good scars was achieved. None of the patients had any major complication, including loss of premaxilla for any ischemic episode or vascular compromise of premaxilla, and there was no any skin dehiscence of the lip. There was no also no fistulas documented. On post-operatively, the first case being older, the elastic traction was performed to gradually retract the premaxilla, and the follow-up period ranged from 6 to 24 months. And dental arc and position of premaxilla were examined clinically and documented photographically on each session of visit. And follow-up period, it was not noted that the premaxilla was minimally mobile in all patients on post-operative follow-up. As to the author's knowledge, there were few reports of one-stage surgery with vomerine ostectomy to repair complete bilateral cleft lip with severely protruding premaxilla before this study. And Padua et al. Suggested that protrusive premaxilla could be surgically repositioned after 6 to 8 years without respect on mid-facial growth. And single-stage primary operation was relatively easier to perform, and as there was no scar tissue, unlike prior lip adhesions, in single-stage surgery was successfully performed with good primary lip repair. What is the limitation of this study? It was single institution-based study, small number of patients, and lack of evidence on effect of simultaneous rhinoplasty during premaxillary setback, and lack of standardized orthogonal cephalometric values for severity of protrusion and size to be reduced, and lack of long-term follow-up to see effect of procedure in the mid-face growth. And they didn't mention method of fixation after ostectomy. And the strength of this study is this procedure is cost-effective alternative in setups who are lacking preoperative dentofacial orthopedic appliance like that of our country and most of the African and sub-Saharan countries. So the authors were able to successfully perform in single-stage surgery, good primary lip repair at their center, and they lack long-term effect of procedure in mid-facial growth, and they recommend further confirmation of this surgery with follow-up and anthropometric studies. Thank you.
Thank you.
Thank you, Dr. Adam. Now, Dr. Mikenon or Dr. Antony, your comment, please.
Maybe some problem in the connection.
I think Dr. Antony is not logged in. But Dr. Mekemon here. Okay, Professor Dr. Welsa, do you have any comment?
I think there was some network issues.
I think some issues.
Dr. Omar Farouk. Dr. Rana Hassan.
Dr. Rana in airport, but he with us. Maybe he's something. He told me I am in the airport.
Dr. Arfan.
Okay.
Sir, hello.
Hello, Dr. Arfan. Welcome.
Hello.
Welcome, sir. I'm sorry I got a bit late. I was really looking forward for this teaching session, but I was stuck in surgery. I tried my level best to be on time, but I'm really sorry for that.
Hello.
Yes, we can hear you, Dr. Arfan.
Yes, Dr.
Yes.
Mukonnen, we are hearing you.
Oh yeah, yeah. Thank you. Yeah, there is an issue with the internet. So I don't know. Do you want me to comment on the articles?
Yes, sir, please.
Yeah, thank you. I would like to thank Dr. Adam. Is really very nice. So the first article is done by me and my colleagues. It is a descriptive study, as he mentioned. I think it is a first study which looked into a little bit countrywide, because the hospitals involved are distributed throughout the country, and in fact, it catched only those patients who are admitted for surgery. It cannot be representative, but it gives a very good information. I don't know, I'm sure there might be a birth defect registry in Egypt because they are advanced. We still didn't have a birth defect registry. We tried to look into the situation in 2015. What we found was that there is no relevant data on birth defects, which is really very important. I think we are pushing, and the Smile Train is also supporting to establish birth defect registry, which will play a huge role in early diagnosis and management. So that is what we are working currently on, establishing birth defect registry. But the findings are not in that study are not really very much different from other African studies, which are hospital based with a lot of under ascertainment. But as I mentioned, they give some information. And the other article, which is some sort of a case series, there is a similar study as, which was published, I think, not very long ago by a Brazilian surgeon who is collaborating with us. It is the same thing, setback, early setback and lip repair. He said that we all feel that if the premaxilla is touched at that age, the midface retrusion will be severe. But what his argument is that he has a long time follow-up, and what he suggested is that since we don't touch the growth center, there will be no growth impairment. We have not yet tried it, but this is what he tried to convince us. I've operated with him at premaxillary setback, but other cases at my unit. He has visited more than 3 times our unit. So it is one area I think we are going to test it in the future. I think these are my comments, and I would be happy to address any question related to the first article. Thank you.
Dr. Mekanon, regarding the first article, was there any big difference in the demographics of the patient or the collected data from the other countries or of other African countries? Because I think so more or less it's the same. The incidence is more or less the same. It's around 4 to 6 for each 10,000 live births. Is it okay?
I'm sorry, can you say it again?
For the demographics of the collected data of the patient or the children with the cleft palate and with the orofacial cleft, was there any difference between the Ethiopian collected data and the other countries around like Kenya and Sudan and so on? Because the same, I think it's the same incidence, it's almost the same incidence, ranging between 4 to 9 or 4 to 8 actually for each 10,000 live births.
I think the problem is all these studies, African studies, are hospital-based studies. So there is similarity, similar from the Nigerian study, from recent Ugandan study. The demographics, these are all Ethiopians. Non-Ethiopians were not included. In fact, there were some Somali patients which were not included in this study. As I told you, the problem is these studies are all hospital-based, and hospital-based studies are prone to understatement. The similarity is because some of the studies are, for example, the Nigerian study and the Ethiopian study, the source of the data is the same, smile train.
And train, yes.
Yeah, so it is those who are really presented themselves for treatment, they are the one who are included. And in our countries, there is a lot of stigma attached to anomalies, and there are many people who are not presented to the institution for treatment. So they are, they give a baseline study, but they can be used as a baseline study, but not representative.
From your experience,
I don't know if I answered your question.
From your personal experience, the average age of the presentation of the patient with orofacial cleft for surgery in Ethiopia, they are coming early or later?
That's a very good point. When we started, the average age was around adults, like 15, 16. But currently, when we started, we thought the estimated backlog was around 500,000 backlog of unoperated clefts. But, in Ethiopia, Smile Train recently celebrated its 100,000 cleft surgery in Africa. And of these, 1/4 is done in Ethiopia. So extensively surgery was done now. We brought the average age is now very much down. Like now, recently we started operating at the age of 3 months. But when we started, we operated as when the child is above 1 year. Because of lack of experience, because of anesthesia risk. But now we thought that we have really educated experience and the anesthesia is safe. Now the average age could be like around 5 years.
Yes, but is there any awareness program there?
Yes, now there are a lot of media, radio, TV advertising of the cleft activity in the country. Cleft surgery is now going on in many hospitals, but still we are behind the multidisciplinary care. We have only speech therapists at now at 2 institutions. Orthodontist care only in 1 unit. That's our unit. Surgery-wise, primary and secondary is advertised all over. Media is very much involved. So because of this now, the average age has gone significantly down, and we see less and less adults with an operated cleft. Today, for example, we have operated a boy of 16 years old. It is, I think, in the past 2 years, this is the first to be operated at this age in our unit.
Thank you, Dr. McKinnon. For the second article, what is your impression about doing osteotomy for vomerine osteotomy for this protruding premaxilla, especially to not be, it will affect the growth later on. What is your impression about that?
You are asking me?
Yes. Your impression about.
Yes, my impression was that this will interfere with growth. But Dr. Fernando, who is, we are collaborating with him, he tried to convince us that if we are not touching the growth center, this will not be a problem. And he tried to show, he is also published in the Cleft Rhinoplasty journal, a very nice article. I can send it to you if you would like to see it. I don't have my own experience, but according to his experience, what he's saying is that this will not interfere. And the fact is, mentioning for this is that the growth center should not be touched.
Thank you, Dr. McKinnon.
Thank you very much.
Dr. Wael Saar with us, Professor Dr. Wael.
Yes, Mohammed.
Yes, sir, your comment, please. Yeah,
yes, I'm very happy to be with our fellows in Ethiopia. Regarding the first paper of epidemiology, or the incidence of the cleft disease in the country, as our doctor said, consultant said that it is a hospital-based, which is not that accurate, I know. So when we grow and when they develop 1 or 2 or 4, more than 4 centers all over the country for the cleft disease, they will have a better documentation. So documentation will, as you said, Dr. Salah, that the documentation and very important, increasing the awareness of the people, increasing awareness of the population, that this is a disease which is curable and should be treated as early as possible, so as not to affect the hearing or the smell and the speech. This will push the people to know that there are centers for the treatment. So it will take time, but I'm very happy to see these first steps towards the documentation and treatment. Regarding the second paper, I'm very happy, not only by the technique. I know the techniques are not so variable between countries, but our resident who presented the case, he followed a very good rules regarding how to present a journal club or paper, and the items he said and the limitations, and so he followed a good rule. But I have one comment only regarding when he said in the limitations. I think he said something regarding rhinoplasty, but rhinoplasty is not done at that early stage. of age, so we can postpone it until the growth of the cartilages of the nose are well developed. So it may be the last step. Also, we have to mention to our fellows or juniors what's the meaning of the multidisciplinary approach regarding treatment of orocleftal disease or craniofacial clefts. So it would be very, very beneficial for the patient and for the surgeons to do this, and to know that we have so many specialties like speech pathologist, genetics, audiologist, otolaryngologist, laryngologist, psychologist, plastic and reconstructive surgeons, and dental services. Also, the nursing is very important to how to handle the patient, and the mother how to feed her baby. So the multidisciplinary approach will increase the awareness of the doctors and the people. Thank you very much to be with you. I'm very happy to hear this from our colleagues. Thank you, Mohammed. Thank you.
Thank you, Dr. Wael. Dr. Wael, your impression about the late effect of cleft lip repair. Usually, we face the patient with receding or premaxilla actually in the late age, and usually we want to augment this area. Do you feel this correction later on will affect?
Do you mean that the correction, when it is done as early as possible, will minimize the complications of late repair?
No, I mean the opposite. If he didn't follow the patient for a long time to the late age. Usually, when we face this patient at late age, at the time of rhinoplasty or something like that, we have flattening of the upper lip and the premaxilla, and usually we try to make augmentation at the area of the upper lip at this area.
I think we have to differentiate, Mohammed, between two items, or maybe three items. Especially in bilateral cases, early management of early management, but by whatever technique of the bilateral cases of lip will by itself treat the protruding maxilla.
Yes.
Yes, this is. But regarding the rhinoplasty, I think it's not. We have to wait. Sometimes when we do the Millar operation, you repairs 20 or 30% of the flaring of the lower lateral cartilage, which is very weak, I know, in these patients. So I have one lecture for the cleft lip repair in rhinoplasty in cleft lip patients. So this is a very complicated item, and because the patient has very weak lower lateral cartilage, he doesn't have a good columella. So as you said, in some cases you need to augment, not to protrude to recede the premaxilla. If the patient has the same pathology, one of the patients he showed us. He also had Mohammed some receding chin also.
Yes.
So because it's a syndromic, some syndromes. So we have to treat the patient as a whole.
Yes,
not as a cleft lip only or cleft butt.
Thank you, Troy.
Welcome.
Can I comment on? Sorry.
Yes, please.
Concerning rhinoplasty and team care.
Yes, this patient I meant that yes. He has a receding chin.
Micrognathia?
Actually, you cannot say macrognathia, but because he's still young, his mandible not fully developed. But it's more that protrusion of the mid face more than the chin.
You were going to comment on rhinoplasty?
When you are mentioning rhinoplasty, You mean you're mentioning about open rhinoplasty? Because usually straightening the septum with the periosteum and also doing a Markham type rhinoplasty, we usually do during the lip repair, but we don't do early adolescent like tip rhinoplasty. It can be done like at the age of 12. But when you do lip repair, we do Markham type, and sometimes we also do primary straightening the septum with the periosteum, not being aggressive to dissect. We don't dissect the septum, but we just do straightening. That's
Yes,
what
I mean open rhinoplasty, as you mentioned. I mean open rhinoplasty, which will maybe hinder or deprive the cartilage from its blood supply, especially in that growing age. But the only part of the septum you can see during your surgery is the caudal part of the septum. But the whole septum, as you mentioned, we don't have to dissect the perichondrium from it.
Yes, I agree that. And concerning the team care, I think team care is very, very important for us because parental acceptance is also a problem in our situation. So if there is no good parental acceptance, feeding will be impaired and it will be very difficult to manage the child. So counseling on feeding, counseling on the birth defect is one very important thing which the junior plastic trainees should understand. So team care starting from counseling, which improves parental acceptance, and feeding demonstration, because in the early stage of cleft, that is one huge problem. Parental acceptance and feeding are really very crucial, and depending on the capacity, like having orthodontics, speech, ENT, and genetics, pediatrician is very crucial. But in the early at birth, management should concentrate on counseling, parental counseling, to improve acceptance and feeding. Thank you.
You're welcome. Thank you very much.
Thank you, Dr. Mekanon and the Professor Dr. Walsa, Professor Dr. Mekanon. For
maybe Dr. Yes, I would like to say most welcome for Dr. Adil. It's the consultant from the Morocco. He will be with his team maybe next month or after for Journal Club. Maybe he will see something. Dr.
Okay,
Adil.
Thank you for the invitation. I'm already happy for sharing this time with you.
Maybe if you have any comment.
About the patient, yeah.
About the case.
I think that it's the most important thing is about the bone growing. You must do the bone construction. After that, we cannot speak about the septum or about something other. I think it's very important to do reconstruction, bone reconstruction first, in the early time. I think it does it, and after that, when the patient has 16 years old or something like that, we can start to doing rhinoplasty or septoplasty, or most of them.
Okay.
Dr. Any comment from the audience?
Dr. Omar, you're there? Are you there?
If anyone
He always, yes, he's always with us.
Dr. Omar Farouk.
Yes. maybe far away.
Okay, any question? Any other comment?
I don't know if in your country you can touch the septum or not, because I think some, yeah, in your teams.
No, actually, I'm speaking about myself. I'm only doing on the lower lateral cartilage only, just from the same incision, just trying to straightening it or to release the adhesion, just to help remodeling it. That's it in the primary session. But I'm not trying to do formal rhinoplasty in the first session.
Yeah, of course, we must respect all soft tissue. We mustn't touch anything for doing the rhinoplasty first. After when we have a cleft lip, bilateral cleft lip, normally we mustn't touch anything in the nose. We must waiting the child growing. After that, in the 16, I think 16, between 16 and 19 years old, can doing a lot of operations, like not only in one time. We do a lot of times for doing a good job, I think.
Actually, to be honest, we are occasional surgeons for such cases. Actually, I think these cases should be treated from the beginning to the end in a specialized center, so you can gain a cumulative experience from the beginning to the end. Because usually you are operating the baby while he's young, but you cannot see later on your late result. If the patient coming after 15 years, 16 years, usually he's not coming to you. Or the opposite, you are receiving a patient coming for secondary rhinoplasty, he was operated before 15 years or 16 years before with another surgeon far away from you. You don't have any data about the initial surgery. But if this patient operated in a special center from the beginning to the end, I think this will be much more better for the patient, for like multidisciplinary team, and they can gaining more experience about what's going on from the beginning to so you can compare your result and your effect, because there is a lot of debate about even the age of operation. The earlier the better for the speech and the function, but on the opposite it affects the growth of the bone and the bed face and so on. There is some debate about that. Some prefer to delay to allow for the growth, but it will affect the speech and so on. So it's different, but if it is operated in a special center, in a multidisciplinary team, I think this is the ideal, and this is the best for the patient and for the surgeon also, I think. This is my opinion, my personal opinion.
Yes. Dr. Omar, online, he's online now.
Good evening, everyone.
Morning, Dr. Omar.
Yeah, my opinion is that since we have started doing primary rhinoplasty at the time of lip repair, we have got better results. I can add that. And we have not to do much at that time when you do the lip repair. But it has it has long lasting results. Because what we have seen that then you have to do still touch-ups a lot doesn't need to be done later on. If we compare our results, what we had before, I can see 7-8 years back, when we are doing lips only and we are doing rhinoplasty later on, comparing with the results we are seeing this time, there are far better noses and which need lesser touch-ups later on, compared to when we are not touching the nose in the initial stage. It is my experience that we have better results and less work is to be done on the nose later on. And many noses, I think if there is many noses, we have to do little, or patient may be satisfactory with what has been done in the primary stage. They are happy and they are satisfied with that. I want to add that thing only. Thank you.
Thank you, Dr. Omar. Okay, I think
Thank
we
you so
are in
much.
time now.
Yes, time for say. I would like to say, I want to say something. My mobile is not nice to fix. I would like to thank you for the Professor Mikani to be with us today with his team from Ethiopian team. We are grateful for having you with Dr. Adam, Dr. Anthony, and thanks for all the professors and audience that attend today. And thank you for all. I wish next month or after we will arrange with the Morocco, inshallah. And I will let Professor Salah to end the session. And also the Dr. Zia has surgery. That's why he attended with us at the beginning. At the end, he left for the surgery. So thank you.
Thank you,
Thank you
Dr.
very much.
Thank you, everybody,
Thank you
and
very
thank you, Professor
Thank you.
Mikenwan and Professor Anthony and Dr. Adam for this presentation, and thank you, everybody from the Ethiopia team. And thank you
very
for
much.
the whole audience, and especially Professor Dr. Wael Sar, Professor Dr. Omar, and Professor Dr. Adil, and Dr. Irfan, and everybody with us, and Dr. Hala. And wish you all a nice eve or afternoon according to your time. And see you next
Night.
month, inshallah.
Good night now.
Bye-bye. It is night here now.
Here night. I don't know. In Morocco is still, and also in Ethiopia. Good
It
night.
is night here.
Okay.
Yeah,
Bye.
Thank you very
Okay.
much,
Thank you very
everybody.
much. Bye-bye.
Thank
Thank you.
you. Bye.